So next is V12, pancreatic neuroendocrine tumors. A 45-year-old woman who has been previously well attends your outpatient clinic. Computed tomography performed to investigate an unrelated complaint shows a 1.8 centimeter enhancing lesion in the head of pancreas. The enhancement characteristics of this lesion suggest a neuroendocrine tumor. A history of hormone hypersecretion needs to be elicited. But 90% of the times, pancreatic neuroendocrine tumors are non-functional. And specific biochemical tests for hormone screening should be performed only as guided by the history and symptoms. How would you manage this patient? So size alone is unreliable predictor of malignancy. Serum chromogranin A may be useful, including may be useful. And endoscopic ultrasound guided biopsy can confirm the diagnosis of neuroendocrine tumor, also to obtain information on grade, mitotic index, and Ki-67 proliferative index. Is a biopsy necessary? She is currently asymptomatic and has no biliary obstruction, so there is no rush to operate. The location of her tumor would necessitate a Whipple procedure for oncological removal and a major procedure with significant morbidity and mortality. Having evidence to confirm before surgery would be important and need for biopsy. Biopsy confirm a well-differentiated tumor, less than 2 mitosis per high power field, and Ki-67 is less than 2%. It is possible to after observation as the risk of malignant is low. The histology is consistent with the well-differentiated neuroendocrine tumor, low mitotic index, and Ki-67 is low. How would you counsel her? So I would still offer, I will explain to the patient the histology, and I will still offer her Whipple procedure as there is still risk of malignancy. She will remember always, and she is fit, and the surgery would be curative. If she is not keen for surgery, then serious cross-sectional imaging and close follow-up. But during the follow-up, if anything happens, if there is evidence on the change in the tumor size, then she might end up having a surgery. While enucleation is an option, it does not remove the draining lymph node, and nodal mets have been reported even in less than 1 centimeter. What is most common functioning neuroendocrine tumor? So insulinomas comprise 35 to 40% of all functional pancreatic neuroendocrine tumor, and patients present with the Whipple's triad of hypoglycemia, and in symptom it resolved with glucose administration. In contrast to the other neuroendocrine tumor, 90% of the insulinomas are solitary and benign. These should tend to be smaller than 2 centimeter. How would you work up and manage the patient with suspected insulinoma? So first of all, diagnosis is via admission in the patient in the hospital for controlled environment and 72-hour supervised fasting test. When patient has symptoms, then we should take the blood and look at the level of serum insulin, glucose, proinsulin, and C-peptide. And inappropriate raised insulin at the time of hypoglycemia and symptoms clinches the diagnosis. And the first line localization is best with CT MRI pancreas, which localize up to 80% of the insulinomas. Endoscopic ultrasound may be more sensitive, especially for the tumor less than 1 centimeter. If all these things failed, CT, MRI, EUS, then there is calcium arteriography, a very complex test. What is the treatment of localized insulinoma? So ideal tumor to consider enucleation if tumor localized on the preoperative imaging, favorable location, superficial, and relation with pancreatic duct is clearly delineated. Formal resection of pancreatic duodenectomy or distal pancreatectomy. Otherwise, if frankly malignant or suspicious or large size more than 4 centimeter with lymph node mets, vascular or other local invasion, then a formal resection as well. Discuss briefly the surgical management of pancreatic neuroendocrine tumors with liver-limited mets. Fewer than 10% of patients with hepatic mets are candidate for curative resection. There is no level 1 evidence, but there is a retrospective data that's showing that long-term survival is achievable with R0 resection. Debulking of the hepatic mets is indicated only if there are significant symptoms, either locally or due to hormone secretion. A large resection of at least 90% of metastatic disease should be aimed at, and liver transplantation is not universally indicated for metastatic PNET. Thank you.